Hi, my name is Caitlin, and my presentation is on disseminated intravascular coagulation, also known as DIC. So, here's a case history taken from a published case presentation in the American Journal of Clinical Pathology. A 44-year-old man with a medical history of hepatitis C, cirrhosis, and chronic kidney disease sought treatment at the emergency room for altered mental status and an ammonia level over 400 micromoles per liter, but the normal range is between 11 to 51 micromoles per liter. The patient was given lactulose, however, his mental status worsened to a point where he required intubation. The patient was started on antibiotics because of his concern for sepsis and multi-organ failure. The etiology of DIC is always secondary to another complex disease. In the case history, the patient had a medical history of hepatitis C, cirrhosis, and chronic kidney disease. Some etiologies of DIC include direct tissue damage, which includes trauma, surgery, and burns. Cancer can also play a role in DIC, such as solid tumors or acute promyelocytic leukemia. Toxic or immunologic reactions such as blood transfusions, transplant rejections, and even snake bites. Vascular disorders such as thrombosis and large vascular aneurysms. Pregnancies, complications as well, such as preeclampsia or amniotic fluid embolism. Also sepsis, which is when the body has an unusually severe response to infection by a microorganism, can also be another cause to contribute to DIC. In the case history, it mentioned that the patient was started on antibiotics because of his concern for sepsis, which could lead to organ failure. Here's the background of DIC. DIC is secondary to significant disease, meaning that you cannot just develop DIC on its own. DIC can be acute, which is known as uncompensated, or chronic, which is known as compensated. There are less than 500,000 patients per year in the United States, but remember, since there are about 328 million people in the United States, that's not such a large number. If a patient has sepsis, the occurrence of DIC increases to between 30 to 50%. DIC is also found in about 1% of all hospitalized patients, but about 9 to 19% of admissions in the intensive care units. If a patient develops DIC, the mortality rate increases to between 10 to 50%. In DIC, men and women are affected equally, even though pregnancy is a complication, and there is no specific age range. Therefore, the risk factors of getting DIC is dependent on an underlying significant disease, such as cancer, like acute promyelocytic leukemia, will have tumor cells release and expose the tissue factor. Well, what is tissue factor? I'll go into more detail about it when I discuss pathophysiology, but basically it's a primary cellular initiator and a cofactor of blood coagulation or blood clotting. Another risk factor is having sepsis, which can cause damage to vascular endothelium, which is bad because it results in exposure of tissue factor yet again. Blood transfusions can lead to diluting clotting factors and antithrombins, where antithrombins are proteins that circulate in the plasma and serve as regulators of blood coagulation. Pregnancy complications are also a risk factor to DIC because placental tissue as well as tissue factory activity is exposed to the mother's circulation. Continuing with risk factors, direct tissue damage is a major one. Trauma, such as damage to endothelial cells, will increase pro-inflammatory cytokines. When there is stimulation of these pro-inflammatory cytokines, endothelial cells can express surface tissue factor. DIC is present in about 2/3 of patients with systemic inflammatory response to trauma. Connecting back to the case history, the patient had hepatitis C and cirrhosis, a chronic liver disease. Hepatocytes are involved in the synthesis of most blood coagulation factors, which include prothrombin, antithrombin, and fibrinogen. When the liver is damaged, the synthesis of these factors will decrease, and there's a possibility of accelerated intravascular coagulation, among other roles of the liver. So here's just one of the slides for pathophysiology. So DIC is the tendency to bleed despite widespread clots, which can lead to organ ischemia, infarction, and necrosis. Hemostasis is the process of forming a clot after injury to prevent blood loss. In DIC, after a blood vessel injury, the process of hemostasis is out of control. It can lead to the formation of many blood clots throughout the body. So, as the process of blood clotting is occurring throughout the body, these clots use up all the platelets and all the clotting factors. Since these factors and platelets are being consumed, there will be bleeding at the slight injury of the blood vessel wall. DIC is also known as consumption coagulation due to the fact that because of the widespread clots throughout the body, this actually consumes all of the clotting factors and the platelets that are needed when there actually is injury to the vessel. So in layman's terms, DIC is a mix of having too much clotting, but also having not enough. So this slide continues into our pathophysiology and briefly goes over the sequence of events for DIC. We all know that DIC is secondary to complex disease, so these steps cannot just happen on its own unless it's brought on by something else. Anyways, the first step is procoagulant exposure. This is when the blood is exposed to one or more procoagulants, such as tissue factor that I've mentioned before. The blood is normally protected from this. The second step is the activation of the coagulation or clotting cascade, which then leads to the production of thrombi, which consists of both fibrin and platelets. This can occur in both microvasculature and or larger vessels. Excessive formation of thrombi will then lead to the consumption of coagulation factors, which is coagulation coagulopathy. Step 3 is fibrinolysis activated, where fibrinolysis is the breaking down of blood clots with the generation of FDPs, or fibrin degradation products. When FDPs are present in large amounts, they interfere with fibrin clot development and platelet aggregation. Step 4 is the consumption of platelets, fibrinogen, and prothrombin. As I mentioned before, DIC is known as uncompensated because it is exposed to such large amounts of tissue factor over a period of time, as well as a significant generation of thrombin. This leads to a very fast consumption of coagulation factors that is much greater than their production. Fibrin degradation products are also generated to disrupt the normal fibrin polymerization and fibrinogen binding to the platelet surface, which interferes with the fibrin clot formation, as well as platelet aggregation. The consumption coagulopathy, along with the high concentration of fibrin degradation products, leads to severe bleeding, which can be helped by given fresh frozen plasma, as the patient will soon get, and platelet transfusions. In chronic DIC, there's exposure to smaller amounts of tissue factor, so production of coagulation factors and platelets are able to compensate, unlike in uncompensated or acute DIC. The last step of DIC can lead to organ damage. This is the result of reduced perfusion, bleeding out, and or thrombosis. This can be contributions from DIC itself or the primary conditions that set DIC off, which are often intertwined. Organ failure may result in significant morbidity and mortality. So this is the normal physiology of hemostasis. We can see in this photo here, which is blood clotting. Though in DIC, this process of blood clotting is happening throughout the whole body. Here's a damaged blood vessel, a formation of platelet plug, and the development of a clot, all which steps are normally good, but in DIC, this process is abnormally activated and happens often and throughout the body. So this explains the last slide basically, where hemostasis is the process to stop blood flow where a clot forms to prevent blood loss. Blood changes from a liquid state to a gelatinous one. In DIC, this process of hemostasis is occurring, but the process of coagulation and fibrinolysis is abnormally activated and occurs throughout the body, so meaning it is widespread. So this is an animated pathophysiology picture in understanding DIC, which is also known as consumption coagulopathy. So in the last slide, I talked about hemostasis, which is the process of blood clotting is abnormally activated and then is widespread and happening throughout the body. So the blood clotting factors is happening throughout the whole body, which then creates a problem when we actually do need blood clotting factors, like when there is even slight injury to the blood vessel walls. The platelets and the clotting factors are being consumed way too much, which can lead to excessive bleeding when a blood vessel is damaged and needs to have clotting factors present, but there actually are none. So DIC can either be acute or chronic, where acute is known as uncompensated and chronic is known as compensated. Acute is over a few hours or days and is known as being uncompensated or decompensated because of the blood is exposed to an overwhelming amount of tissue factor. The consumption is so much greater than the production of platelets and clotting factors, where there's also a significant generation of thrombin. The consumption coagulopathy, coupled with the fibrin degradation products that I discussed in the second pathophysiology slide, will lead to severe bleeding. The consumption is greater than production in chronic DIC as well as acute DIC, but in chronic DIC, since it's developed over months, there are smaller tissue factors instead of an overwhelming amount, so there can be some compensation here. In acute DIC, there's significant generation of thrombin, but in chronic DIC, it's just increased fibrinolysis, or the breaking down of fibrin, and increased production of thrombin. The blood is continuously exposed to smaller amounts of tissue factors so it can compensate. Remember, the signs and symptoms of DIC are related to the underlying significant disease, which was hepatitis C, cirrhosis, and chronic kidney disease in the patient case history. DIC can present in many different kinds of signs and symptoms due to the fact that it is related to the underlying significant disease. Though there are bleeding manifestations such as oozing of blood from wound sites, mucosal surfaces, and IV catheters. Petechiae, purpura, and ecchymosis and septic shock can also occur. There is also a macrovascular and microvascular thrombosis, which leads to cyanosis of toes and fingers, jaundice, and renal dysfunction of oliguria and hematuria. The patient did not mention to have any bleeding manifestations, but he had cirrhosis, which is a severe liver disease when there is late-stage scarring of the liver, probably caused by the hepatitis C. Because of this, jaundice could occur when there's too much bilirubin in the blood and the liver cannot filter it from the bloodstream, which causes the skin and eyes to look yellow. Of course, there is chronic kidney disease in the history of the patient, which evidently can show as renal dysfunction, such as scanty urine, oliguria, or blood in the urine. So we see here in this photos, we see petechiae and purpura versus ecchymosis. So petechiae are deep red or even reddish purple skin discolorations. Petechiae are about 1 to 3 millimeters, while purpura are a little bit larger, but still less than 1 centimeter. These can both be rounded or even sometimes irregular and flat. Ecchymosis is a purple or purplish blue, which can fade to green, yellow, or even brown over time. It is much larger than petechiae, as we can see in the right-hand photo. These can be rounded over irregular, and they can have a central subcutaneous and flat nodule or a hematoma in the middle. Ecchymosis is secondary to bruising or trauma, often seen in bleeding disorders like DIC. I mentioned 2 slides ago on the connection between macrovascular and microvascular thrombosis and the case history of the patient, where the patient had developed cirrhosis and chronic kidney disease, and that can translate into jaundice and renal dysfunction, among other things. Other symptoms related to DIC are related to bleeding manifestations. Blood oozing is due to the blood clots in the bloodstream, which blocks small blood vessels, eventually consuming clotting factors and platelets, which causes excessive bleeding. Ecchymosis is a skin discoloration that we saw in the last slide, and it is a characteristic of platelet number or functional abnormalities. Blood clots that reduce blood flow can block blood from reaching organs, and that can present as cyanosis or renal dysfunction, among many other things. This diagnosis is still from the American Journal of Clinical Pathology, and it is paired with the case history that I showed in the second slide. Laboratory results were taken, and these normal range of numbers are seen in the white parentheses here. Rather than reading all of these values, I made a key that is seen to the left-hand side. Elevated lab values are in blue, and the normal lab values are seen in green. We see that the white blood cells, international normalized ratio, also known as INR, prothrombin time, or PT, activated thromboplastin time, or APTT, and creatinine are all elevated because it is much higher than the values in the normal range. Platelet count is the only normal value we have here, but the rest are elevated. So the slide continues in the diagnosis. The patient continued to deteriorate, and the following lab values were obtained. Note that the normal ranges are in the white parentheses, but the initial values from the first lab tests are done in the black text. We see that INR, PT, APTT continue to just increase, getting farther and farther away from the normal range. D-dimer is now also elevated, while platelet count, which was normal in the first test, has decreased as well as hemoglobin and fibrinogen values. Eventually, the diagnosis of DIC was made. Fresh frozen plasma, cryoprecipitate, platelets, and packed red blood cells were ordered, but the patient went into cardiac arrest and died before all of the blood products could be given. Connecting back to the background, we remember that when a patient has DIC, the mortality rate can be between 30 to 50%. So there's minimal diagnostic criteria for diagnosing DIC, and there are quite a few tests that need to be done to figure it out. Therefore, the diagnosis of DIC is a constellation of factors which includes general signs and symptoms, medical history, and laboratory tests. These tests in the next few slides are lab tests that were run on the patient, which can all help in diagnosing DIC. PT and APTT results are compared to a control sample of normal blood. Partial thromboplastin time and activated partial thromboplastin time are screening tests to evaluate a patient's ability to appropriately form blood clots by measuring seconds it takes for a clot to form in a sample of blood. PT and APTT are very similar, but in APTT, an activator is added which speeds up the clotting time. International Normalized Ratio, or INR, are found using the results of PT test to measure how well the patient's blood clots. INR is the international standard for the prothrombin time. Continuing with the diagnosis, there are 3 more tests. The D-dimer is a leftover substance in the blood after clotting, and the test can see if there are high levels of D-dimer, which is an indicator of a major clot. Fibrinogen is a protein produced in the liver, where a test done can tell how much is in the blood. In DIC, the body can be using too much fibrinogen, leading to decreased concentration in the test, and the patient actually did have decreased fibrinogen. Also, the platelet count determines the number of platelets in the sample of blood. In DIC, there are low levels because of consumption coagulopathy when all of these platelets and clotting factors are being consumed throughout the whole body. Other lab tests were done on the patient, which included hemoglobin, creatinine, and white blood cell tests, but none of those can help make the diagnosis for DIC, but instead can be indicative of another complication. Treating the primary or underlying disease is the main goal for treating DIC. For example, the patient was giving multiple antibiotics for his concern for sepsis in the case history. But actually treating DIC, where a bleeding patient with acute DIC has short-term treatment of blood component therapy based on his deficiency in his lab test. In the patient, he received fresh frozen plasma, cryoprecipitate, platelets, and vitamin K. And these are all just to make up for his deficient lab tests. So these are just my references, and this is the end of kind of a long video on DIC. Thanks for listening.